Lovely. So thank you, Efthymios, for that introduction. Yeah, so for those who don't know me, my name's Dan Murrell. I'm a emergency medicine consultant and a subspecialty consultant in paediatric emergency medicine at Luton and Dunstable Hospital. And I'm also an honorary fellow in paediatric critical care retrieval at the Children's Acute Transport Service in Great Ormond Street. So I've been asked to do a quick, little presentation on how to approach fits, faints, and funny turns in the paediatric TD. So what I'm going to talk about is I'm going to talk about the approach to how we approach children who present with fits, faints, and funny turns in the ED. I'm going to talk about some of the challenges they may present for non-paediatricians and talk about important conditions that you may not have come across and things to look out for. So, what are the challenges? It's a really common reason for children to present to paediatric ED with what sounds like an episode of a seizure episode or a funny episode or a collapsing episode. And often they do get seen eventually by paediatricians for special interest, but they can be quite hard to manage and diagnose in ED. So they represent about 71 children per 100,000 in the under fives, especially in increases in deprived areas. And it can be, so 1 in 10 children may have one-off funny episodes, up to 1 in 5 children under the age of 15 present with one episode of syncope, and about 1 in 200 children in the UK are diagnosed with epilepsy. Epilepsy can be, or seizures can be very difficult to diagnose, and often the terms can be confused and the way they present can be challenging. There's descriptive terms and the history may be quite difficult to untangle. So a seizure we would define as a transient occurrence of signs and symptoms due to abnormal excessive synchronous neuron activity in the brain, whilst epilepsy is an enduring predisposition or tendency to generate seizures. And epilepsy is an umbrella term for a vast number of disorders, but often it can mimic other things, which we'll talk about. So broadly, you're looking at sort of the ways it may mimic other conditions, and it can be misdiagnosed up to about 30% in children. So misdiagnosis is quite common, which can have knock-on consequences of inappropriate treatment on anti-epileptic therapy, non-treatment of the actual diagnosis, restriction of activity, stigmatism, and anxiety. So what we'll do is we'll get you to think about a case to start off with. So, got a 3-year-old, you're in ED, you get a pre-alert with a 3-year-old who's presenting with an ongoing seizure for 5 minutes. They're 5 minutes away. They haven't been able to get any observations or IV access, and they started a bit of oxygen. And what I want to ask is, how would you go about approaching a patient like this? So the thing I have in my head, the way I approach it, is what will I do when the patient presents if the seizure is ongoing? So what I'm going to do with status epilepticus, and what would I do if the seizure is terminated or the seizure collapse episode is already terminated, so it's not ongoing, and whether the seizure is provoked, unprovoked, or whether there's a breakthrough seizure, because how you manage this will be slightly different. I'm sure lots of you have seen this before. So this is the new APLS algorithm for status epilepticus, which is defined as a seizure lasting more than 5 minutes or repeated seizures without full neurological recovery. If a seizure is lasting more than 5 minutes, it's unlikely to spontaneously terminate, so may need pharmacological therapy, and the risk of refractory seizures increases with the duration of the seizure. And complication-wise, if the seizure is ongoing for more than 30 minutes, there's a risk of neuron death, injury, complications such as catecholamian surgery, so hypertension and dysrhythmias, respiratory compromise, so aspiration, hypoxia, hypercapnia, neurogenic pulmonary edema, hyperpyrexia, so metabolic problems, hyperglycemia, lactic acidosis, and rhabdomyolysis and leukocytosis. What you want to do is balance the risk of some of the pharmacological therapy with terminating the seizure. And a lot of these decisions aren't particularly linear. So What you want to identify is it a provoked seizure? So we're talking about either febrile convulsions, acute CNS infections, metabolic or electrolyte abnormalities or conditions, trauma, and CNS bleed and stroke. Because I think the way you would manage those would be different to if it's a unprovoked seizure or someone who's known to have epilepsy. So like you guys have said, so think ahead and prepare your team and anticipate what you might face. So often these patients will have difficult IV access. So preparing drugs for the IV route or buccal route or rectal route, or preparing for intraosseous access. Often what I would do in resus, if the seizure's ongoing, is I'll get the nurses to get the infusions ready, because by the time they've drawn that up, you'd probably be at that time frame to give it. And if you're anticipating, for example, there's a history of head injury or a patient needs a CT scan, and and the seizure's refractory, whether early airway management and RSI would be appropriate to facilitate neuroimaging. Often deciding, and often what can be challenging, I find in a lot of patients, is whether the seizure is ongoing or not. So often children may have funny movements, or may look like they're having a seizure, or if it's not fitting with their normal seizure pattern, whether it's when it stops or starts again, if it's a seizure that's ongoing. And often what I've found, I've come across a couple of times, is clinicians mistaking seizures with posturing. Often posturing would occur in when you stimulate the patient. So say if you do a jaw thrust, I would treat that slightly differently to a status epilepticus. So posturing to me is a distressed brain, and that requires urgent neuroprotection. But again, the decision for proceeding to an RSI can be quite complex. So you have to consider patient factors. So especially patients who are known to have difficult epilepsies or have recurrent seizures, often may have syndromes which may make the airway and difficult. There's patient factors, so you need to consider where, if you do an RSI, where the patient might go afterwards. Often what you guys might not realise is that a lot of these patients, when they land on PICU, often get extubated within hours of them arriving. And often what will happen is that, say, if they have to go very out of region, whether that's in that patient's best interest to go very out of region where their normal regular paediatrician's not around, it is obviously another balancing with whether you would want to extubate locally or manage how you would manage the patient locally. And obviously, if there's a question of the diagnosis or the whether it's provoked or unprovoked, will pertain to whether you decide whether you need to proceed to RSI. Often, from my retrieval point of view, we often get called about these children about what to do and what drugs to give. Now, as a PIC retrieval specialist, often what we will say is you just follow the APLS algorithm. And actually what you do need to do is, if you have questions about alternative anti-epileptics, is speak to their usual paediatric neurologists. And like I said, with thinking and preparing a team, I think often what you need to do is try and anticipate who you might need, what the problem might be, where you need to go, and where this patient needs to go if the seizure is ongoing, or when the seizure terminates, or if you get the seizure to terminate, where else what's the next step? So how do you approach patients presenting with collapse who have fully recovered is the other sort of difficult challenge. So what can we do to reduce misdiagnosis in the ED? So the really important thing is history. Sometimes I think it's very important maybe not to get words in patients' mouths, and often what I'll say is, oh, can you describe exactly what they were doing at the time? So what they looked like, what they were doing. If there's no witnesses, I think it's important that you try and identify if there was any witnesses. So whether if you need to contact school or nursery needed, or if you weren't there with a paramedic handover to contact or get the paramedic notes. And listen very carefully to handovers and ask specifically what happened. Videos can often paint 1,000 words, but they need to be good quality videos, and ideally of the whole patient, so head, shoulders, arms, legs, to see exactly what the abnormal movements were. Ask about previous episodes. whether there's any prodromal symptoms beforehand, which can be difficult in younger children. Any history with any recurrent medications can be important. Important to ask about family history and ask about other things. So whether whether in a menstrual cycle, the environment, stresses, and important to try and do a HEADS assessment. For those patients who are known to have epilepsy, it's really important, I think, to ask about the symptomology of the seizure. So was their seizure pattern they had today the same? And whether this breakthrough seizure was just a one-off or a recent trend of increasing seizures, and check the dose and medications compliance of those medications, and ask when the last dose change was and whether they gained weight. And it's very important to do a thorough examination, so looking at tone, which is often missed, reflexes, and not forgetting about cardiac causes, so listening up for murmurs, femoral pulses, hepatomegaly, and looking for cardiomegaly. We'll talk about a case. So, got a 14-year-old female who's come in, whose collapsed Curie cause, was previously well and was standing up at school for a long time and felt unwell and then fell to the floor. Noticed to be shaking while she was on the floor, but now is fully recovered. And for her observations, as you see, so name three appropriate management steps. So I think hopefully a lot of you will realise that this is likely to be a vasovagal syncope. So it's a really common presentation, especially in toddlers and sort of pre-mid-adolescence. So you need to think of 3P, so posture, precipitant, so standing, theor, or stretching, and prodrome. And it's usually one of them has caused it. It's usually just a one-off, and often you can reassure these patients. So often these patients will have some sort of prodrome symptoms, so would have been standing for a long time, felt unwell, nauseous, dizzy, lightheaded, would have had some sort of postural symptoms. It's very important to get a detailed history, so ask about family history, ask about certain red flags, which we'll come to. But the two most important investigations, or three important investigations you need to do, is an ECG, a blood glucose, and a lying standing blood pressure. If it's repeated, or if you've had repeated episodes of vasovagals, then please consider whether they're having anemia, so if they ask about heavy menstruation, and look for postural hypertension. Again, is quite common in teenagers related to rapid growth. And the main treatment for that is increase the fluid and salt intake and safety netting advice. If it carries on, then it may be a GP referral to look for other sorts of syndromes, so like POTS, for example. So, case number 2. Next patient is a 15-year-old male. He's coming with a collapsed Curie cause and watching TV. And whilst he was watching TV, he went very stiff. And he's had a previous episode whilst playing rugby and is now fully recovered. And there are his observations. So you might realise that there might be 1 or 2 red flags in this patient. And this is more likely to be a cardiac syncope. So syncope that's exercise-induced, or syncope whilst the patient's lying flat, with a known murmur, signs of heart failure, family history of sudden death, and ECG abnormality would be red flags for a cardiac condition. Most commonly, it can be structural, so hypertrophic cardiomyopathy, as in it's about 3 in 1,000, or maybe related to, say, aortic stenosis, but other arrhythmias, channelopathies, and conduction defects. But what I would say is if you're in doubt and the ECG looks funny, then it's worth consulting a paediatric cardiologist or your local cardiac centre to have a look at the ECG and see if there's any concerning features. So common cardiac conditions that to think about. So the first one is prolonged QT syndrome. Often the cause of it is either congenital or acquired. So often there's a few drugs, so antibiotics such as erythromycin or danzatron, some anti-epileptics can cause it. And so it's important to take a detailed drug history or recent drug history. Electrolyte imbalance, raise intracranial pressure and hypothermia. And then there's some congenital conditions, so which can cause prolonged QT syndrome. So the normal QT interval should be between 350 and 460 milliseconds. And the QT interval, as you can see here, is the start of the Q wave to the end of the T wave over the isometric line. So if it doesn't quite hit the isometric line, what you want to do is draw an intersection, and where it intersects, that will be your QT interval. The main treatment for it is to stop any precipitant. So you do some blood tests, take a detailed drug history, and if it's ongoing, do give IV magnesium and speak to a cardiologist. So this is sort of another spot diagnosis. So what ECG abnormality can you see on here? Yeah, so Brugada syndrome. So yes, this is Brugada. So Brugada syndrome is a sodium channel channelopathy, which is again congenital. And what you tend to get is ST elevation and T wave inversion in leads V1, V2, and V3. Treatment is mainly identification, may be associated with some, as it's a sodium channel defect, may be associated with some types of epilepsies, but the main treatment for this is ICD insertion and beta blocker therapy. What's the abnormality in here? Another important condition. So yes, again, this is Wolff-Parkinson-White syndromes. Short PR interval with a sloping QRS complex, or is known as a delta wave, an important predisposition into tachyarrhythmias. But like I said, the important thing is if you see we see lots of people with funny turns and lots of ECGs. So if it sounds or looks abnormal, ask a senior and speak to a paediatric cardiologist. You can send them the ECGs and they'll be able to advise what they think over the phone. So, case number 3. A 9-month-old male is brought to ED by his mother, and he's noticed has some funny movements with increasing frequency, and he's a bit more withdrawn and miserable, and there are his observations. So, what clinical features would distinguish between a seizure or a hyperkinetic movement? So, approaching people with funny movements in the ED, I think the first thing to say is what I often will say to parents is what is worrying them about the movement. So, and worrying features is if they're particularly young or and is associated with developmental delay, then that's of concern. And deciding whether these movements are abnormal or not, or whether it's a seizure or not, can be really difficult. So, a seizure tends to be originate in the cortex. The movements tend to be regular and more simpler, and may have some autonomic features, generally the patients are unaware it's going on. Whilst hyperkinetic movement disorder mainly affecting deeper brain structures, ranging from dystonias, which are involuntary muscle contractions, tics, chorea, myoclonus, and tremors, and don't tend to have any autonomic features to them. But with the hyperkinetic movements, often it's good to get videos, talk to the parents about what they're concerned about or if there's any other worrying features, but also not to forgetting if the child is able to, is ask them how they feel when these movements are going on. And then speaking to a paediatrician or paediatric neurologist is helpful. But if it's ongoing and you think there's a seizure going on, then, for example, if it's a particularly young child and you can't tell if they're unaware or not, then following the APS algorithm and consider using benzodiazepines wouldn't be unreasonable. But again, balancing that decision making with your seniors is helpful. So this patient was the patient I saw who actually we suspected had infantile spasm. Infantile spasms or West syndrome is quite an important consideration too. It's a rare form of epilepsy, mainly affecting under 1s, but can affect up to 2 years old. And we tend to present with head drops and crunches and shoulder drops, which it's a sudden movement where we suddenly bend forward and it clusters. It can be quite subtle and often can be confused with reflux and other movement disorders, but importantly, it's associated with developmental delay or behavioural changes. And these patients need referral and urgent diagnosis. So often they'll have inpatient EEG to look for hyperarrhythmia brainwaves and is treated with high-dose steroids and bigger Bactran. Other things to consider, so breath holding spells. So again, fairly common in sort of under 1s where it's associated with pain or emotional upset where they sort of hold their breath and go blue. There's not any prodrome to it, but it lasts seconds. Sometimes you may get some associated jerking with it, but often you'll get a rapid recovery and you won't have a post-ictal phase. Whilst syncope will present with, as we talked about with a trigger, precipitant with pain, fight or standing, will have some prodrome to it. Duration will be seconds. Sometimes you might get some jerking, but you again a rapid recovery. Whilst with seizures, the recovery is delayed, and usually the duration lasts minutes rather than seconds. Febrile convulsions, again, another really common presentation. So these are seizures which are associated with high fevers, often ENT infections, and those under 18 months may have subtle signs of CNS infection. So that's something to bear in mind, especially if they're quite young. And be aware if they've had a recent decreased level of consciousness or recent use of antibiotics that put them at a higher risk of CNS infection. It's not associated with intracranial severe metabolic disturbance. So these patients, if they have a simple febrile convulsion, so that age between 6 months and 6 years, it was a generalized non-focal seizure lasting less than 15 minutes and only occurring once in 24 hours, and complete recovery within an hour, then you can maybe consider them for discharge. And then what we talked about before is on breakthrough seizures with people with known epilepsies often can be very challenging. It's important that you review if they had individual emergency care plans, so whether they had previous drugs that A didn't work or they've had quite severe reactions to it, so often like benzodiazepines associated with apneas. And having an observation period and contacting the epilepsy team they're known to see if they've got any review coming up or whether a review can be brought forward and whether any therapy needs to be adjusted or any investigations need to be expedited. But it's also important to consider compliance issues, so what the home circumstances, are they getting their medications regularly, and whether there's any sort of safeguarding issues that you need to consider or sort of extra support that the family needs. The other condition that I've come across, and it's quite rare, but again important, is something called status dystonosis. So this is repeated involuntary, so it's a dystonia which is constant and it's not stopping. So dystonia being involuntary, sustained or intermittent movement of muscle contraction, which can be potentially life-threatening. But it's an exacerbation of a known dystonia disorder. So most commonly cerebral palsy, but these patients will either be known to have cerebral palsy or a known metabolic condition. It's often triggered by precipitants, so usually pain, intercurrent illness, stress, so like recent surgery or dehydration. And the way you grade it is it's graded between 1 and 5. Grade 3 and 5 are the ones that often will need urgent treatment. So grade 3 being muscle contractions where the patient's unable to tolerate lying flat. Grade 4 is that with associated metabolic compromise and pyrexias, and grade 5 being respiratory, renal, CNS compromise. And it's 2/3 of status dystonosis is triggered by stress. Peak incidence is between 5 and 16 years old. Don't forget the differential, so whether this is status epilepticus, neurological malignant syndrome, or serotonin syndrome. And the complications are quite wide ranging, so it can range from respiratory failure, rhabdomyolysis, pain, or compartment syndromes and hypothermias. And the mainstay of management is supportive, so keeping the patient nearby mouth, minimal handling, giving them analgesia and IV fluids, and escalation management of the muscle tone, so chlorohydrate, midazolam, and colodine to help reducing the muscle contractions, or whether sometimes if it's extremely extreme, whether an induction of anesthesia to temporarily stop the muscle contractions whilst you get all these other medications on board. I think the final question is a lot of the time is whether you've got a patient who may or may not have had a seizure, but is now fully recovered and it looks well, whether these patients need to be admitted or discharged. So I think having a one-off seizure doesn't automatically require admission, but I think you need to think about the context of the severity, the frequency, and the impact on the family, and whether they need extra time or reassurance. I think if there's diagnostic uncertainty and there's a lot of parental anxiety, then a referral and potential admission of the paediatrics may be appropriate. And the patients who you would consider for discharges, patients you can't find a provoking cause for, who are fully recovered, who have got a place of safety, care and parental reassurance, and follow-up arranged with a first fit clinic with a normal ECG and a normal blood sugar. So in summary, we talked about the challenges and management of these patients. So I think the most important thing to take away is it's all about history. So you take really careful histories, try and get the patients to, or the carers to describe what's going on. Good quality videos are really helpful, but don't forget cardiac causes, don't forget metabolic causes. And if you're in doubt with a patient who you think has got ongoing movement and you're not sure that it's a seizure or not, then follow the OPLS algorithm and speak to a specialist. Thank you very much.
I just had one question, Dan.
Yeah.
I just wondered if you come across sort of neonatal status often with your transfer job, and if you often see people using the different algorithms recommended by some of the transfer teams rather than APLS?
So I have seen neonatal status, but generally if they've left hospital, then you treat them down the APLS algorithm. But what I would say is if you've got anyone under 6 months old who's presented with a seizure type episode, it's more likely that there's a provoking or underlying cause that needs investigation. So often those patients need to be admitted and investigated.
Can I ask you one question? When do you believe that it's safe to stay in the hospital rather than to transfer the child?
It's a conversation between the anaesthetic team, paediatric team, and the transport team, because those decisions are relying on lots of different factors with those sort of cases. So generally, the patients you might have difficulty is patients who are known to have a seizure disorder, who have a breakthrough seizure that is resistant, and that they've had an RSI. So you terminated the seizure, but there's no other sort of precipitating factors. So, they're hemodynamic stable, they didn't need fluid resuscitation, they were a straightforward airway, there's no neurosurgical concerns. And if all of those criteria hit, then you could potentially talk about a trial without stopping the anaesthesia, see if you can wake the patient up and see if there's any ongoing seizure. So that's a conversation. So it's not every one case is the same. But I think it's certainly if there's any sort of hemodynamic instability, difficult airway, or anxiety about managing the child afterwards, then that's a discussion that you'd have with the team about what's best to do for that patient. Because also it might not be in that child's interest to, say if you're in Luton, that the nearest bed's in Merseyside, for example. So that might happen. So often that's why you need to have a discussion. So someone's asked about EEGs and status epilepticus in those scenarios. So I've never done an EEG in the ED itself. Certainly, I think that'd be difficult to do, and I haven't seen it done. I don't think it has much of a role in the ED itself, though in PICU, often with sort of anaesthetic resistant seizures, then I've seen it being done then, but I think I'll leave that to Dr. Rose to answer.
Yeah. There's nearly no role for it acutely in status epilepticus. It doesn't really help you, except on cerebral function monitoring on PICU. Can help you if you've got ongoing electrical seizures despite anaesthesia. But even that's quite rare to do. By then it's usually burnt itself out and you can bring them up fairly quickly. So yeah, EEG is not a magical thing. I'll be talking about it a little bit more, hopefully, in a moment.
Any other questions?
I have a quick question, if that's okay. It's a very quick one. I just wanted to ask with regards to hypoglycemia. So let's say if you find someone who is approaching that 5-minute mark with you with a seizure, and you notice that BM is low, and you start treating the hypoglycemia. Once they pass the 5-minute mark, do you still proceed with the APL itself, like status epilepticus, even though you know the trigger?
So I would treat the trigger. So you treat the hypoglycemia first. In my experience, if they're hypoglycemic and they are seizing, correcting the glucose will stop the seizure. What often you might find is that, especially if it's prolonged, that they might not regain consciousness very quickly. So the one case I can remember is that they had a compromise. We corrected the glucose, but then they were very obtunded and were having to manage the airway. So that's when you would probably not go down the APLS algorithm, and you'd probably go straight to neuroprotection, because the reason why they're unconscious is because they were hypoglycemic, which has probably potentially caused some neuro damage. So you want to neuroprotect them rather than treat the seizure. So and you would have thought I would have thought the seizure would be terminated when you correct the glucose.
Thank you.
Well, thank you very much, everyone.
Thank you very much. It was amazing. Thank you very much for your time.